Good day. Thank you so much for having me here at the annual Clinical Assembly for 2021. My name is Sarah Mowry, and I'm a neurotologist in Cleveland, Ohio at Case Western Reserve University Hospital's ENT program. Today I'm going to talk a little bit about management of the difficult mastoid cavity. I think we can all agree and recognize that these are some of the most difficult patients that we see in the office after they've had surgery but continue to have issues with their cavities. I do have a few disclosures to make, none of which are relevant really to this discussion. The objectives for our talk today are to list the indications for a canal wall down tympanomastoidectomy, the common causes of problematic cavities, identifying some key features in a good primary canal wall down surgery, and some interventions that you can use to help manage a difficult cavity. So just as a brief recap, the surgical goals for cholesteatoma surgery would be the primary goals of eradication of disease and creation of a dry, safe ear and to minimize the risk of recurrence or recidivism in these patients. Secondarily, we aim to improve hearing and preserve normal anatomy when possible. Canal wall up and canal wall down surgeries are different. The canal wall down surgery is certainly the gold standard or has been in the past. It has excellent exposure of the entire middle ear and epitympanum. It has a low recidivism rate, somewhere less than probably 15% or so of patients develop recurrent cholesteatomas over time. The problems with canal wall down surgery, of course, are that they have cavities that can be problematic in terms of moisture trapping. They can have chronic otorrhea. They do require frequent cleanings, and there are water restrictions for these patients. On the contralateral side is the canal wall up tympanomastoidectomy, which does maintain and preserve most of the anatomy of the ear so that patients do not have to have frequent cleanings or maintain a dry ear canal. But the cons are that there is significantly worse exposure of the epitympanum in these patients, and the recidivism rate can be quite high. And you can see why this is. On the right-hand side of your screen is an intact canal, and you can see that the canal itself, as well as the ossicular chain, does block your view of the anterior epitympanum, which is where cholesteatoma oftentimes likes to hide and is one of the primary sites for recurrence in these patients. As opposed to a canal wall down, which is on the left-hand side of your screen, which demonstrates a wide exposure of the middle ear and epitympanic space. However, that space can be quite large, especially in a well-aerated mastoid, and these patients can then have problems because of the large nature of their cavity. When you look back historically at the literature for recurrence and recidivism rates in canal wall up and canal wall down, basically what you'll see is that in the canal wall up group, authors have reported recurrence rates of somewhere between 15 to as much as 60%, whereas in the canal wall down group, somewhere between 5 to 20% recurrence rate over time. And keep in mind that these cholesteatomas can recur as many as 20 years down the line, although most people, when they have recurrence, it does occur in the first 6 to 8 years after their primary surgery. So in my office, my indications for a canal wall down would be poor patient compliance or patients who I think are unlikely to follow up or come back for a second look operation, which I generally do recommend when we do a canal wall up procedure. Um, Patients who have large defects in their canal wall, which make them difficult to preserve any sort of functional ear canal. And then the other time is very elderly patients or patients with significant comorbidities who are poor medical candidates for a second operation. When we do canal wall down surgery, the primary surgery is really important to make sure that we do a good operation for the patient. And there are 5 things that my mentors really drilled into my head about making sure that you do when you do a good canal, to get a good canal wall down cavity. And those 5 things are first and foremost is to lower the facial ridge, which reduces the retraction of the TM into the middle ear and into that sinus tympani and hypotympanic area, which can be quite hard to clean if the ridge stays high. Removing the tissue from the mastoid tip is also very important, and essentially removing all of the bone lateral to the digastric allows the collapse of the sternocleidomastoid muscle into this space. So we're making a smaller cavity. It also removes air cells, which in the mastoid tip, when they are present, especially in patients with chronic otitis media, that mucosa that exists within the tip can be a source of continued or persistent inflammatory disease in the mastoid cavity if they're not removed. You want to make sure that you remove all of the sinodural air cells. Again, this mucosa is a nidus for persistent inflammatory disease, and it can be the reason why a bull will mucosalize rather than epithelialize, because mucosa grows and repopulates much faster than a dry epithelium. So when there are mucosal rests that are left in the sinodural angle, those mucosal rests can repopulate out into your mastoid cavity. Widely saucerizing the bowl, so that means taking down the edges along the tegmen tympani, making sure all that cortex goes down essentially to the level of the tegmen, and posteriorly taking that back all the way past and to at least to the sinus, and then many times past that. When I put my finger back in the surgery in the space, what I'm feeling for is that there are no ledges where it would prevent soft tissue from falling into the cavity. Wide saucerization seems paradoxical to the goal, which is to create a small cavity, but when you widely saucerize and really flatten those edges out, it allows the soft tissue to slide into your cavity. So it's really important to do that. Wide meatoplasty is probably the most important thing that you can do when you're doing a canal wall down surgery. A wide meatoplasty will correct a lot of sins, is what my mentors told me. So I create a very large meatoplasty. My patients, I certainly counsel them about that beforehand, that their ear canal shape will be different and it will be bigger. So it is a cosmetic defect for some patients, and you'll see in some of the following slides what a really wide meatoplasty can look like. But it's really important because it allows the cavity to ventilate and it allows you to clean the cavity effectively. In a patient who has a wide meatoplasty with a well-created cavity, many times these are cavities that essentially clean themselves. So they frequently don't need to come in every 3 to 4 months and can come in once a year, which is a significant benefit to the patient because coming into the office frequently is really disruptive to many people's lifestyles. So once you've done all the bony work and you've done those 5 things, which are really important, what are you going to line your cavity with? Many people use free fascia taken from the temporalis muscle. Unfortunately, a lot of the times when I'm operating on somebody, it's not their first rodeo, and they very often have had part or much of their fascia harvested for prior operations. So sometimes I'll use pericranium, which means that you elevate the temporalis muscle and you're going to use that periosteum, essentially, that's underneath the muscle to line your cavity with. It's nice, it's thin, and it's pliable. But it does require a little bit more work to harvest it. And the patients certainly have more pain because you're going to end up mobilizing their temporalis muscle. A split thickness skin graft is always an option for these cavities and works quite well. You just need to discuss the donor site morbidity with your patients because the split thickness skin graft site is usually the most painful part of that operation for a patient. I have colleagues who like to use alloderm to line their cavities with and have had good success with that. There are also xenografts that are available on the market. The most popular right now currently is Biodesign. There are other reports of more exotic kind of cavity linings, including amniotic membrane. And then for cavities that you potentially are concerned about, and you want to have a vascularized tissue line your cavity, a temporoparietal fascial flap is a good choice. And we'll talk a little bit about that flap towards the end of the talk. So the other thing that some authors do in combination with some of these different linings of the cavity is to obliterate some of the space. So obliterating the mastoid cavity space can be very useful. And many people will use a combination of things, including non-vascularized tissue, such as bone dust or bone pate, which they've collected early in the operation. Other reports exist of bioactive glass, cartilage strips, and hydroxyapatite, which can be used to fill in some spaces, particularly the sinodural angle and the lateral places there or aspects of the cavity. You can also use a local rotational flap, and I use this very often, an inferiorly based musculoperiosteal flap or an inferiorly based palva flap, and I'll show you an example of what that looks like towards the end as well. You can also use vascularized temporoparietal fascia flap, or you can even swing some muscle down into the cavity. And many people, as I mentioned, use a combination of these, both vascularized and non-vascularized tissues to minimize the space of the cavity. This is what I wanted to talk about in terms of one of the things that you can do to minimize the space in your cavity. This is an inferiorly based myofascial flap, and you rotate this up into the cavity here. This is the mastoid tip, the root of the zygoma. And once all this bone is gone, this will fold in to minimize your space, and you can lay your graft over the top of it. The good news is that most patients, when you do an operation for them, achieve a dry cavity. And even in revision surgeries, a dry cavity is possible. There is unfortunately still a subgroup of patients who have persistent otorrhea, granulation, and mucosalization within their cavities, which make their cavities wet and draining, which can be quite bothersome to the patient. So this is an example of a patient who has a very wide meatoplasty. You can see you can fit probably 2 thumbs in there. But she had significant problems with her cavity lining. And so we did a number of things to try to help her get that dry. But that is a difficult cavity. So she Well, let's talk a little bit about managing this difficult cavity. So, when I'm thinking about how to manage the difficult cavity, one of the first things is what are the agents that have been used previously and what should we try to use next? And then what does the cavity look like? What's the tissue that's in there that's giving us trouble? The first thing I think about is, well, what are the agents that have been used in the ear? So, wet agents, including antimicrobials such as boric acid, gentian violet, and acetic acid, are certainly useful. Antifungals are useful, and then, of course, the old standby of antibiotic drops, which can be in combination with steroid medication if necessary. However, many times a wet agent is part of the problem because moisture is definitely the enemy of a dry mastoid cavity. And so many times when I see a patient in the office who is having trouble with their cavity, they've been on drops sort of persistently and nothing is working. So the first thing I do is switch them to a drying agent. My go-to is boric acid, which I like because it comes in a nice medical grade powder. It doesn't tend to cake or turn into concrete, which nystatin powder does sometimes do. It becomes very hard and adherent and is sometimes quite difficult to get out, especially if it's really stuck down onto the tissue. Now, the other thing I listed here is CFS powder, which I sometimes refer to as the nuclear bomb powder. It works great. The medications that it consists of, I've listed there for you. It does require a compounding pharmacist to make this, and it can be very expensive, like $200 for 10 capsules, depending on your pharmacy. And most of the time, insurance will not cover a compounding pharmacy agent. So that's sometimes problematic and really out of reach for a number of patients. In the office, I do have access to boric acid and nystatin powder. Fortunately, because of the regulations in Ohio, I cannot have CFS powder stocked as clinic stock. It has to be per patient. So that's a little bit of a bummer, but it does work exceptionally well if your boric acid and nystatin powder have failed. Sometimes what we find, even when we've minimized the size of our cavity, is that there's granulation tissue and mucosalization within our cavity, which are making the space wet. So first thing with the granulation tissue especially is to remove as much of it as possible and to cauterize it. And I often will use silver nitrate, especially in the bowl. That's pretty safe back there. I also will sometimes use trichloroacetic acid, which comes in an 80% concentration straight out of the bottle, which gives you some cauterization activity. The other material that I really like is gentian violet. So it's an antimicrobial, it's non-specific, but it goes on wet and then it dries very quickly and will tend to have persistent activity for long periods of time. I then usually put a drying agent on top of where I've been working. So many times this is a multiple application thing that I'm doing. So we cauterize something, I then put gentian violet over the top of it, and then I apply a drying agent. If you've done this in the office and you're still having trouble with recurrent granulation tissue, it's worth getting a CT scan and looking to see, is there a nidus for what's going on? Is there something going on in the cavity that you can't see, that you missed at the first operation? And you may want to consider revision if there are a lot of residual air cells in the mastoid, because the mucosa that's in those mastoid air cells is going to be problematic and may be the reason why you're having failed medical management. So the next thing I wanted to talk about was moisture trapping, which is a challenge for patients because many of these patients have a significant degree of conductive or mixed hearing loss as a result of their operation. And our audiology colleagues are really great at getting them good amplification. However, it's at the expense of fitting them with a large occlusive ear mold. Those large occlusive ear molds do trap moisture, and that can be a big problem for these patients, moisture trapping. And so it's worth having a discussion with the patient about some hearing rehabilitative options which don't affect their cavity. And that may include just taking the hearing aid out altogether if they have a really good ear on the other side and can tolerate that with their lifestyle. The other conversation to have would be an osseointegrated device, which can be a great alternative for these patients because you really bypass their whole non-functional conductive mechanism. If a hearing aid is really the only option for the patient for whatever reason, I would strongly encourage the patient to use a drying agent, and many times that involves a hair dryer, so pretty low tech, and lots of people have them at their house, but get some air down into that cavity. Intermittent use of boric acid, and I instruct all my patients on how to apply boric acid themselves and provide them with a small insufflator that they can put boric acid in their own cavities when it feels wet to them. And then I strongly encourage everybody to get a dryer box for their hearing aid if they're going to be using a hearing aid in that ear. The other option, depending on the pattern of their hearing loss, is particularly in conjunction or discussion with your audiologist, could an open mold hearing aid be an option for this patient? Excuse me. All right, so you've tried all these conservative things and the ear is still a hot mess. So what are you going to do now? Well, I think, get imaging. Think back to the operation. Think about the 5 things that we talked about, the 5 surgical steps that are really crucially important to getting a dry cavity. Is it a small meatus? Do they need a revision meatoplasty? Do they have retained diseased mucosa? Or in the case of a retraction, which may happen, especially if you are able to salvage large portions of their native TM, they can have retraction pockets which have recurrent cholesteatoma in them. Also, I think it's important to think about, is there a systemic problem with the patient? Does the patient have some other medical comorbidity that is impairing their wound healing, whether that's diabetes or an autoimmune disease? Osteoradionecrosis is certainly something that we see a lot in our tertiary practice. And then there's other sort of weirder things that exist out there. But I would certainly encourage you, if you think that there's a systemic problem, to consult and a liaison with the appropriate other subspecialists. Excuse me. And then when all else fails, consider revision surgery. So what is that revision surgery look like? Well, there's a lot of options, which I think is a good thing to know, right? So probably the simplest thing to do would be an ear canal closure if your meatus is smaller, and you can rotate the skin that lies along the tragal cartilage. You can elevate that and rotate it backwards towards the root of the helix and close it that way. It is really, really important, of course, to get all of the skin out and making sure that you can get all of the skin out of the cavity, and the middle ear is really important so that they don't have an iatrogenic cholesteatoma later on. I then usually fill that cavity with fat taken from the abdominal wall, and that works quite well for many patients. For patients who have other issues, it's very reasonable to think about a local rotational flap. Again, the inferiorly based musculoperiosteal flap works, a temporoparietal fascia flap, temporalis muscle flap. And then if you don't have great options there for whatever reason, I think working with your reconstructive surgeon to potentially harvest a submental island flap or a supraclavicular island flap, which we've done both of those at UH with good success. And then, sort of when all else fails, a free tissue transfer is not unreasonable. ALT radioform is not an unreasonable tissue source for these cavities. And we use free tissue transfer much more commonly in our cancer population who don't have good vascular supply in this area if they've been previously radiated in particular. So the TPF flap, again, is a great source of well-vascularized, robust, and reliable tissue. I'll be honest with you, I do not harvest this flap. I contact my handy-dandy reconstructive surgeons, and they help me harvest this because they're certainly much better at it than I am. But it's an extension of the SMAS and the galea. It's supplied by the superficial temporal artery and vein, and it is a really pretty robust flap. The skin flap's elevated just deep to the hair follicles, and you can have a very wide arc of rotation with this flap. You just have to be aware of the fact that you are going to transect the auriculotemporal nerve when you harvest it. You have to be very careful about the frontal branch of the facial nerve, which is deep to the TPF and is generally located anteriorly, so you want to stay away from that area. The TPF flap is certainly the local workhorse in this area, and it can be rotated down to line your cavity if you need vascularized tissue. If you don't have that option, or you have tissue, you have a very large meatoplasty that needs skin, you could do a skin graft over your TPF flap. That's certainly reasonable. The other option is something called a submental island flap, which is harvested from the neck and then rotated up into the cavity. We've done a number of these at our institution. It provides vascularized tissue. It has a great skin paddle. It's a good color match for the area. Then you've got a closed cavity with good vascularized tissue, which could potentially accept a cochlear implant for a patient. It's a great choice for patients who have underlying comorbidities that make their cavities difficult to heal, such as autoimmune conditions or osteoradionecrosis of the temporal bone. So this is a patient pre-op and post-op. She had a wide meatoplasty. She had a troublesome cavity, and she needed a cochlear implant. Post-op 1 month, the meatoplasty is closed. It's healing well. She's got a good skin match, and then that skin paddle behind the ear is starting to thin out a little bit. At 5 months out, she still had some puckering and dog earring on her neck, which we ended up revising for her. This is another patient who is about a year out, and you can see she had a great cosmetic result with a nice little bit of a neck lift as well for her. She's one of our cancer patients who had osteoradionecrosis, and we had trouble getting her cavity to be healthy, but that worked well for her. So there are a number of techniques that are described to achieve a dry, safe cavity. Mastoid obliteration is feasible with both autologous and non-autologous tissue. It's really better to do it the first time right with the 5 things that will help you make a good canal wall down cavity. But troublesome cavities can be managed conservatively, and you can get a dry, safe ear even if you have problems with drainage, mucosalization, or granulation post-op. Revision surgery may be indicated if the patient fails conservative therapy, and you can certainly consider using vascularized tissue to line or obliterate your cavity. So, I'd like to thank everyone for attending today, and I'm, again, sincerely, it was my pleasure to be here, and I'm honored to be able to present this information. If you have any questions, please don't hesitate to reach out. I'm available at my email address, and you can follow me on Twitter. Have a great day.